In this session, I've been asked to discuss age-related macular degeneration in terms of therapy. So I'd like to give an update on some therapy and some of the recent clinical trials. So what we're going to do as far as introduction during this session is just to say that macular degeneration, of course, remains the leading cause of blindness in Canada today. If you're at my last session, we really highlighted the two forms, the dry and the wet. Treatment of dry macular degeneration, right now it's all about the vitamins, so that'll be the topic of my discussion after lunch. And here we'll talk about the new and exciting therapies for wet macular degeneration. So I want to briefly explain to you what are these new therapies and what do the clinical trials tell us in terms of the effectiveness and the safety and the pharmacology of the different treatments that are available. And then after that, I'll mention some of the other new and exciting areas of research, briefly touch on stem cells and gene therapy. So we know macular degeneration, known by many different names, ARMD, AMD. That is the leading cause of vision loss in Canada today, affecting people over the age of 55. And of course, as our population changes, it's having an increasing social and economic cost to our society. The two forms, the wet and the dry, I break them up by the rule of tens. So 10% of people over age 55 have AMD. 10% of that is wet. 90% of people with wet have severe vision loss. 90% of the AMD is dry. Only 10% of people with dry suffer severe vision loss. Treatment of dry comes down to the AREDS 1 and the AREDS 2 studies. The AREDS 1 trial taught us about the importance of vitamin supplementation, and the AREDS 2 trial refined slightly the vitamins that are most beneficial for dry macular degeneration. I can summarize it in case you're not in my talk this afternoon, that the most recent data we have indicates that vitamin C and vitamin E, which were from the first AREDS trial, are still excellent. Beta-carotene from the first AREDS trial is no longer recommended because of its potential risk for lung cancer in smokers. So the new formulations have taken that out. Instead, we use lutein and zeaxanthine, and we also add zinc and copper. And the second AREDS trial showed us that omega-3 fatty acids do not confer any additional benefit for dry macular degeneration, and therefore those will be taken out of the new formulations. It's not to say that they're bad or harmful. They still have many positive effects in terms of dry eye, arthritis, dementia, heart disease. So they're still important supplements, but we just can't tell people to spend their money on those for specifically macular degeneration. So wet AMD, that's mostly what I'm going to talk about now, treatments of wet AMD. Historically, we had laser therapy, which destroyed the wet component of macular degeneration, the leaking abnormal blood vessels, but it destroyed the retina at the same time. It was thrown away in terms of photodynamic therapy, which attempted to target only the abnormal blood vessels, but preserve the overlying retina, and it was effective. Some people gained vision, but the vast majority of people on PDT continued to lose vision just more slowly. So in the modern era now, our new and emerging treatments all at this time involve injecting medicines into the eye. And this revolution has been called the anti-VEGF revolution. The anti-VEGF revolution has really been within ophthalmology an unequaled and unparalleled success. We've been able to take patients who lost their ability to read and drive and see and recognize loved ones, and in some patients we've been able to really restore that and give it back, and in many other patients we've been able to protect their ability to drive and read. So it's really been an exciting time within ophthalmology, specifically within retina therapy, to be involved in treating wet macular degeneration, because now we have a good treatment to offer. And this can really be life-changing therapy. It can have a profound effect on a patient's health outside the eyes in terms of depression, risk of fall, independence. So it's very exciting. But it's difficult therapy to administer. Receiving an injection once a month for 2 years is very difficult for many patients and for many patients' families. And so we're always striving for ways of decreasing that burden of treatment. But these therapies are all about VEGF, vascular endothelial growth factor. So I just want to briefly comment on what is VEGF, vascular endothelial growth factor. VEGF is a molecule, an important molecule that's produced in our body, and it tells our body where and when to grow new blood vessels. So you can imagine when you're a fetus developing within your mother's womb, how important this molecule is to grow new blood vessels in all of your tissues that are developing. VEGF was first targeted in terms of a medical therapy really in cancer research and cancer therapeutics, because developing new tumors, so growing tumors inside the body, had to grow their own new blood supply in order for the tumor to continue to expand. So if we could turn off that new blood supply, we could halt the tumor. And it had some exciting breakthroughs in cancer. Now, it turns out that thankfully, by turning off VEGF, we don't damage existing mature blood vessels, so we can leave alone the normal healthy blood vessels, but have a way of turning off the abnormal blood vessels and causing those blood vessels to regress and disappear. That is actually how it first became applicable to the eye. They noted that some patients who had wet macular degeneration and were receiving this therapy as a cancer treatment began to see better because their blood vessels in the back of the eye from wet macular degeneration were disappearing in conjunction with their cancer. And actually the first trial ever done used the cancer formulation of these drugs in cancer doses to treat wet macular degeneration. But it turns out using that high-dose chemotherapy is dangerous. It can have very nasty toxic effects on the body. And so soon after we first realized the benefit of these anti-VEGF cancer medicines for the eye, we began to start injecting those medicines in the eye and realized that at just a tiny fraction of the systemic dose, we could still have an amazing positive impact on the patient's retina. And that started the whole revolution of anti-VEGF therapy, and drugs now have been taken right from the bench, right from step one, and made specifically to go into the human eye and to treat wet macular degeneration in the safest possible fashion. So this VEGF, this compound that grows new abnormal blood vessels, it does a little bit more than just do that. It also takes those blood vessels and makes them extra leaky, so that the fluid is more easy to leak out of them. And so by turning off by turning off VEGF, by giving anti-VEGF medication, not only do we suppress the blood vessels, but we also make other blood vessels less leaky, which is exactly what we're trying to do in the therapy of wet macular degeneration. Now, it turns out VEGF comes in different forms within our body. There are 4 major subtypes of VEGF-A, and there's also a VEGF-B molecule. And that's important to know because the initial first therapy that was ever developed for the eye to target VEGF only targeted one of the subtypes of VEGF, VEGF 165 to be specific. That therapy was called Macugen. And although it worked and it helped people, it was like photodynamic therapy. It only slowed vision loss. And it turns out you need to target all of the isoforms of the VEGF in order to really turn it off and suppress its nasty effects inside the eye and stop wet macular degeneration. So now our modern therapies are pan-VEGF blockade, which is represented by the classic drug Lucentis. So in terms of VEGF then, by suppressing VEGF, we not only stop leakage, but we cause new blood vessels to disappear, to vanish. The exact goal that we're trying to achieve in treating wet macular degeneration, and at the same time preserve and protect the existing blood vessels that are in the back of the eye that we need to nourish the retina. So to target VEGF, we can target that molecule in what we call the extracellular space. So that molecule, while it's floating around inside the eye, we have different medicines that grab that molecule, bind it up, and destroy it while it's circulating in the eye. We can also block VEGF by stopping that molecule from interacting with the cells in your eye. So we can put a medication in your eye that'll block the receptors. So even though that VEGF is around there, it's not able to bind to the cells in your eye and produce that effect of growing abnormal blood vessels and produce that effect of causing vascular leakage. And finally, there's a third way we can block VEGF, and that involves giving a medicine that enters into your cells and prevents it from working once it's inside your cell. So even though VEGF may come, bind to the cells within your eye, we've given you a medicine that stops the cell from actually responding to it. And so those are primarily different ways of blocking the VEGF molecule. Blocking it in its extracellular space, so mopping up the VEGF before it even interacts with any cells in your eyes, that's primarily done by three groups of molecules. Aptamers, which were represented by Macugen, which we no longer use. Antibodies, such as Avastin and Lucentis, which bind up the molecule. And then the new kid on the block, or the new player, which is the VEGF Trap, which is synthetically derived substrate which is able to bind the VEGF in the extracellular space. We also have anti-VEGF receptor antibodies. Those are the ones that stick on to the receptor for VEGF. So VEGF is allowed to exist within the eye but won't interact with the cells. And then inside the cells themselves, we have things like squalamine, kinase inhibitors, and small inhibitory RNA molecules, which turn off the intercellular signaling pathway so that even if VEGF binds to the cell, it's not able to produce its desired effect. I mentioned that the Macugen molecule is no longer used clinically because it doesn't block all of the VEGF pathways. Lucentis and Avastin are sort of the prototypical ones that do block all of the isoforms of VEGF-A. Of course, when Lucentis was first proven in clinical studies to work effectively, it was truly a landmark, truly revolutionary therapy because it represented the first time ever in the therapy of wet macular degeneration that we could give a patient a drug and tell them their vision was going to get better. So on average, people receiving Lucentis were able to see better after the therapy. No other medicine could have claimed that before. At the same time that Lucentis was being developed, Avastin was being used because that drug had already been approved for usage for other purposes, and people had access to that drug to put in the eye while we were waiting for Lucentis to become fully approved. So it was the first one to improve therapy. Of course, Avastin represents the full-length antibody, represents the anti-cancer drug that's also used inside the eye, and does indeed produce good results inside the eye. Some of the other therapies have sort of fallen to the wayside. Squalamine was one that I gave to patients when I was in the States. We would hook patients up to the intravenous and give this molecule squalamine, which would enter into their cells within their eyes, their vascular cells, and prevent VEGF from working. And it turned out to be very effective as well in the initial studies. However, it was more difficult to hook somebody up to an intravenous and give them therapy compared to how easy it is to just lean a patient back in clinic and inject the drug into their eye. And that was a very quick and speedy process. So medications like squalamine that were given by intravenous have fallen to the wayside, really. The new kid on the block, the most recent medicine, which was just approved in Canada as recently as yesterday, is called the VEGF Trap. You'll hear about it under different names. That's one that I like to use. It's basically a soluble decoy receptor for the VEGF molecule, so it mops it up in the extracellular space, and it does bind the VEGF molecule even more tightly than other forms of therapy like Macugen, Avastin, and Lucentis. So it really is very effective at mopping it up. And that molecule, that drug, you'll hear more and more about it in Canada in the coming months. It is being proposed because it works potentially has a longer acting effect than Lucentis. So whereas Lucentis is designed to be every month, the VEGF Trap has the potential to be used on label according to its recommended dosage scheme every 2 months, which could, in fact, then cut back on the amount of injections a patient needs. So what I wanted to do next was really concentrate on those big three therapies that we have in Canada, Lucentis, Avastin, and the VEGF Trap, and just tell you some of the differences we've seen so far in the studies. The VEGF trap is known as Eylea when it's made for the eye. Lucentis is known as ranibizumab, it's the other name, and Avastin is also known as bevacizumab. But to keep things simple and less of a mouthful, I'll talk about Lucentis, Avastin, and Eylea, or the VEGF trap, so everybody knows the three drugs. They all target VEGF. Lucentis, of course, it targets all isoforms of VEGF-A, whereas the new one, aflibercept, the VEGF trap, it targets VEGF-A as well as VEGF-B and also placental growth factor. So it targets a few more molecules inside the eye which are supposed to be responsible for the wet macular degeneration. These all have different sizes as well. The smallest molecule is Lucentis, and it was designed to be a very small molecule so that it could get through the retina into the subretinal space and target those abnormal blood vessels which are growing up from the choroid. The VEGF trap is about twice the size of Lucentis, and Avastin is about 3 times the size in terms of molecule size as Lucentis. They last for a different amount of time within the human body. So once you inject these medications into the eye, they tend to all roughly last about the same amount of time within the eye. But the molecules that they escape into the human body, the molecule like Lucentis, which was designed for the eye, tends to disappear more quickly from systemic circulation than some of the other options we have, Lucentis and Avastin, Avastin and the VEGF trap, which will last slightly longer within the human body. Approved indications. Right now in Canada, Avastin is only approved as an anti-cancer drug. It has never been approved for use in the eye. Lucentis, as we know, is approved for use in the eye not only to fight macular degeneration, but also to fight diabetes and vein occlusions. So it has 3 approved indications for intraocular use, and therefore it is funded now for those different uses. The VEGF trap is approved for wet macular degeneration, and further studies will lead to its approval in other conditions as well. If we talk about some of the pharmacological differences, again, Lucentis designed as a small molecule to penetrate through the retina, and it was designed to make it as small as possible and take away some of the other components of the molecule so that it would not stimulate inflammation inside the eye, and also so that it wouldn't be pumped out of the eye, less likely to sort of be recognized as a foreign compound and pumped out of the eye, so that it will stay in the eye and not get into your systemic circulation. Eylea, or the VEGF trap, the new kid on the block, I call it, it was designed to fight VEGF-A, but to expand the amount of molecules that it can target, VEGF-B and placental growth factor, to potentially expand its ability to suppress choroidal neovascular membranes. It is a larger molecule and does contain other components like an FC receptor and things like that inside the eye, which theoretically have been postulated to cause increased inflammation and to also allow that molecule to be pumped out of the eye into the systemic circulation more quickly. Now, we have done studies that compare the 2 molecules, so compare Lucentis to Eylea to see which one is more effective. The initial studies, of course, that were all done with Lucentis showed how beneficial that molecule is and made Lucentis act, we could consider it like the gold standard, like the treatment for which other therapies are compared against. And there's many studies that showed the benefit of Lucentis and that Lucentis can be used monthly or less than monthly and effectively. But the new trial, which compares the VEGF trap to Lucentis, were called the VIEW 1 and VIEW 2 trials. So these were studies that attempted to compare VEGF trap to Lucentis. And these were large, very well conducted clinical trials, and they took the current dosing standard of Lucentis being given once a month and compared it to the new kid on the block, Eylea, or the VEGF trap, being given either once a month or once every 2 months, and the once a month was given at 2 different dosages. So it compared 3 different treatment arms to see which was more effective in suppressing wet macular degeneration. And the simple take-home message from that trial is that according to the data, all 4 methods of delivery, that is, Lucentis being given monthly, the VEGF trap being given monthly in either of its 2 doses, or the VEGF trap being given every 2 months, were equally effective in suppressing choroidal neovascular membrane and restoring a patient's vision. So they all turned out to be equally effective. If you get down into the nitty-gritty of the trial, you learn that the VEGF Trap, the every 2-month medication, it was actually given every month for the first 3 months before it went to every 2 months. And in the second year of the trial, when we said patients would only receive the medicine when they needed it, all of the medications were given approximately 4 times in the entire second year of the trial. So in the first year of the trial, by getting the VEGF Trap, patients were able to have the same visual outcome as Lucentis, but get less medication. But by the second year of the trial, patients were getting all the same, all the different treatment options. They were receiving the same number of injections. So it didn't benefit in terms of number of injections in the second year of the trial. However, that study was done by capping how long you could go between injections. So they forced the investigators, even if the macula was dry, to give them a dose at least every 3 months. And therefore, there's a potential then for that medicine, Eylea, to be extended beyond every month or every 2 months and still be effective. Just like we've seen with Lucentis, that we can go beyond once-a-month dosing and still have an excellent effect. The Eylea, or the new kid on the block, may actually be able to extend the treatment interval as well. So I think it's a very exciting time in Canada to have options of new medicines which are available and are approved within the eye, as a way of potentially decreasing the burden of our treatment. However, that has yet to be proven. We're really going to have to see with our own clinical experience which drugs allow us to expand the treatment interval the most and still give an excellent result in terms of patients' vision. I wanted to speak about another very important clinical trial that was released not too long ago. That's the CAT trial, the Comparison of Age-Related Degeneration Treatment Trial. The CAT trial looked at comparing Lucentis to Avastin. Okay, so it was a huge study done, sponsored by the National Institutes of Health in the United States of America to compare the two. And it looked at giving fixed dose Lucentis every month and compare that to Avastin given every month, and then compare that to Lucentis given less than monthly, but only when the patient needed it, and compare that to Avastin given less than monthly, but only when the patient needed it. The take-home summary from that trial, from the initial first year, was that patients did the best if they were giving Lucentis once a month, but that the other therapeutic choices were close, in fact so close that we couldn't say that the other choices of giving the medicines were any inferior to that. But by the second year of the trial, when we started to follow patients longer and longer, we found that patients getting Lucentis monthly still did the best. When you got away from giving Lucentis monthly, patients didn't do as well. So even if you were getting Avastin monthly, you didn't quite do as well. But again, it was within what we considered to be the significance range, so we couldn't say that that was any inferior from a clinical standpoint. The only one that actually fell to be inferior to Lucentis monthly was Avastin when it was given as an as-needed basis. It fell below what we considered to be clinically acceptable in terms of outcome, and patients were doing worse with that medication given on an as-needed basis within that clinical trial. The Europeans did a very similar study called IVAN, which again attempted to compare Lucentis to Avastin, a similar type of breakup, monthly versus an as-needed dosing schedule. In their trial, they weren't able to recruit quite as many patients as they wanted to, so they couldn't break things up as much as they felt they should have when they designed the trial. But they did take all patients who got Lucentis and compared it to all patients who got Avastin. That was a blended group because it took the patients with Lucentis who were getting monthly and combined it with the patients who were getting it on a PRN basis. And on Avastin, they did the same thing, combined the two groups. And in that study, patients had better vision when they entered the trial, so it was slightly more difficult for patients' visions to improve. But that study was inconclusive in terms of showing any difference between the Avastin and Lucentis. When you look at the PRN versus monthly, it took all patients that got dosing as you needed it for Avastin and Lucentis and compared it to patients who got monthly dosing of both Avastin and Lucentis. It was a strange comparison, I felt, because it mixed Avastin and Lucentis together in treatment groups, but it showed that PRN versus monthly was equivalent. Patients did as well overall when they got the medicine every month as when they got the medicine only when they needed it, only when there were signs of disease activity on their clinical examination. So those studies have given us some important information. The one other very interesting point that came out of the European study was that when you were getting Avastin worked beyond the eye. So it suppressed VEGF within the eye, and it turned off the neovascularization within the eye, but it also had an effect on you systemically and turned off vascular endothelial growth factor in the rest of your body as well. And that was a concerning result for many, because when we turn off VEGF systemically, it may have some effects on other areas in our body. And indeed, some large studies querying the U.S. health insurance database and things like that have raised the possible concern of Avastin having more systemic effects compared to other treatment choices. So that was something that was interesting for me that came out of that study. But if we summarize the overall conclusions from the large clinical trials that we have done to date, we know as a take-home message that this anti-VEGF therapy has revolutionized our treatment of wet macular degeneration. Right now in Canada, we're going to have 3 big players: Lucentis, Avastin, and Eylea, or the VEGF Trap. Avastin, remember, was never designed for use in the eye. In fact, the label of the bottle on it says, "Do not put this in the eye." It's relatively cheap, costs about $60 a dose. It has a duration probably in the 6 weeks time period, but there's the concern of systemic effects from Avastin. Lucentis was specifically designed, manufactured, and tested for use within the eye, but it is a very expensive medication, as we all know, and its duration of action is recommended to be re-injected every month, although we know from clinical experience that we can extend that and we can tailor each individual has a different response to that drug, and so we can tailor how often between the injections we need. Eylea, it's the new kid on the block, the VEGF Trap. It's still an expensive medicine, but it has the potential to expand the dosing interval and thereby decrease the burden of treatment. Now, before I wrap up, I want to move on to some of the other medicines that are coming and the other exciting research. I want to talk about a compound called Vista. I want to talk briefly about gene therapy and stem cell therapy for macular degeneration. Vista is another new wet AMD drug. It works slightly different. It targets platelet-derived growth factor, PGDF, which is a different target. We've been talking about anti-VEGF medications. VEGF targets the vascular endothelial cell, these new blood vessels that are growing. As a blood vessel matures, it starts to line itself with pericytes on the outside, which make it mature and robust and less likely to be treatable with anti-VEGF medication. Vista offers potentially the target of stripping away those pericytes and leaving that new blood vessel even more susceptible to anti-VEGF therapy. So it's a potential way of making our anti-VEGF therapy more potent. And it's an exciting new molecule. Some of these studies have shown that up to a 62% additional benefit is conferred when we add Vista to other forms of anti-VEGF therapy. It is not approved yet in Canada, but it's exciting and coming in the future. I wanted to briefly talk on gene therapy. That's been talked about at this conference before. It's a very exciting area of research within ophthalmology. Basically, what we try to do, understand that our cells are made up of building blocks known as genes, that we can replace defective genes by introducing new healthy genes into cells. We can do that by using a virus to carry those new genes into the cell. The issue with AMD is that very many genes have been implicated in terms of causing the pathology. So it's considered a multifactorial genetic disease. As well, there are significant environmental factors that go on to producing each individual's manifestation of macular degeneration. And this is making it a very difficult pathology to target in terms of gene therapy at this time. Stem cells are those powerful baby cells that exist within our cell, within our body, that have the potential to grow into new cells of many different types. We use them all the time. Corneal stem cells are being used right now in all of us to regenerate the surface of our cornea on a daily basis. And retina stem cells have been isolated and cultured and provide a potential new therapy. Some of the limits right now, though, are even if we're able to inject stem cells into an eye, to try to get those new cells to hook up to the existing wiring and to use the optic nerve and the other pathways in our eye to get their signals from the new cells to our brain. That's proving to be a real challenge, as is the fact of safely getting those stem cells to just reproduce where they want and not to continue to turn over and reproduce inside the eye and produce some undesirable effect. So those are big challenges in terms of stem cell therapy, which researchers are continuing to work on. The future, I think right now, the immediate future will be different ways of using existing therapy in terms of longer-acting implants, in terms of other routes of delivery, potentially even topical if we had an ideal solution perhaps. But the future is definitely bright, and we're looking into many new revolutionary pathways to treat AMD beyond just anti-VEGF therapy, which has been an excellent advancement in ophthalmology, but still leaves room for improvement. And that's basically what I wanted to say, to hopefully leave some time for questions. Thank you.
Ilea, I've been reading about for over a year off the internet. It has been slow to come to Canada.
Yep.
And what I read in the other countries, it was having really good results. Is Canada going to pick up on that? Absolutely.
So that drug will be used in Canada soon. One of the big challenges will be funding. Lucentis is a well-established medicine that's funded here in Ontario and in many other provinces. Even after a drug is approved and available, it takes more time to secure funding from the government so that patients can access it and not have to pay a tremendous amount of money. Thankfully, private insurance companies will pick it up initially, and then that coverage will hopefully be expanded. But it has to pass very rigorous tests to prove that it is an improvement and offers a distinct advantage over what's out there so that funding would be made available. In the interim, you can be confident that we do have effective therapies in Canada, and more choice though is very good.
I was wondering about the efficacy of intraocular lenses. I know that they're doing that quite a bit in Europe. And
yes, that's an excellent question. So intraocular lenses have typically been used in the most advanced stages of macular degeneration. So what they do is implant, instead of just the one single lens that somebody might receive when they had cataract surgery, they implant like a pair of lenses that acts like a telescope. So it really provides a lot of high-powered magnification, similar to some of what our visual aid products that are available would do. So it's basically a way of giving a telescopic type vision in the eye by implanting a very complicated lens system. That's an expensive lens system. I firmly believe that our best therapy continues to be the intravitreal injections for wet macular degeneration, and your best alternative right now is to receive the normal lens that you would during cataract surgery and to continue with your injections. But it's another potential treatment for people who have the advanced disease that would no longer respond to injections by trying to give them some magnification. I've seen the lens put in a few patients, and it has a telescopic effect, so it can zoom in on one area, but the compromise is your field of vision, your peripheral vision, and so it's tough for some patients to adapt to that.
How can a patient compare their actual progress? We can see ourselves with the Amsler grid, but what paperwork can we have for our own records to show what is actually going on after each Lucentis injection? So, what our progress is scientifically, we know visually.
So there are tests. Probably the best single test to quantify somebody's response to therapy is the OCT. So the OCT will actually measure the thickness of your retina at each visit, if your physician does it, and gives you a number. So it's 400 microns thick this time, 350 next time, 300 microns thick, and generally speaking, as the retina thins out, the medicine is working, the vision is getting better. So that's probably the best objective measurement that we have. For me, I never treat a test result. I treat patients, not test results. And so for me, the best way I have of following it is how well the patient is seeing and living. So that's the most important thing to me. Can you see? Can you read? Can you still get around? So that's what matters the most to me. But if you wanted something more objective to write down, it would be the OCT thickness of your macula.
Hi. Floaties.
Floaters, yeah.
Floaties. So my father-in-law's been on treatment, although I'm actually not sure which one,
Okay.
but he's plagued with floaties. What causes the floaties? And other than surgery, which I'm told is very risky, and
Yes.
he's not going to try that, is there anything else,
No.
or is there anything being developed to deal with floaties?
So floaters are condensations within the vitreous gel. The vitreous gel is the jelly-like substance that makes up the inside of your eye behind your lens. So if you crack the eye open, it's filled with vitreous, similar to crack an egg open, and you'd see the yolk. So that is a proteinaceous structure, which is very important when we're very, very young because the eye forms around it. As we age, it becomes effectively not needed by the eye, so we don't support it, our body doesn't support it, it breaks down, it degenerates. As the vitreous gel degenerates, it separates off the back of the eye, and the proteins within it coalesce together to produce floaters. So it's a normal aging change in the human eye. It doesn't represent any pathology, but these floaters form within the eye, and they can be extremely bothersome, especially to a patient that has one functioning eye. Because with two good eyes, our body is sometimes able to compensate and doesn't have floaters on this side, so our brain learns to fill in the gaps by what the other eye sees. But if you're monocular, they're even more troublesome. There are surgeries to remove the floaters, and I agree 100% that I strongly recommend against them because surgery has risk. And they're annoying, but they don't cause any sight loss. They're just an annoying thing. There's other solutions that have been proposed, particularly lasers to break them up. I find it takes a small floater and gives you many more smaller floaters and more of them. So I am not supporting that therapy at all. So right now, I basically tell people that hopefully with time the floaters settle to the bottom and become less annoying on their own, but I don't recommend specific targeted therapy for floaters.
I'm here on behalf of my mother, and I would say from what I'm hearing today, unfortunately she's not with me and I'll call her to check, that the treatments have stopped. It was a wet form. She's considering e-sights, the device. Is that helpful to somebody if there is the scarring? Is that going to, it will?
Yeah, absolutely. So although we can't give her more shots because the shots aren't effective in reducing the scar, they only stop the blood fluid leakage. Then when a person has come to the point where the injections are no longer effective, absolutely, I tell them to try any of the technology that's available and suitable to that individual that may allow them to experience more sight by magnification, by other terms. So I think it's a good idea. Different people have different acceptances of technology, so it's important before you pay for something or buy something that you have an ability to test it out, see if it's going to be effective for you. Some technology does take a period of adaptation, so you have to really try it and see if you can adapt to it, and then realize the full potential of that technology. But I wouldn't shy away from at least allowing a trial of those magnifying devices and the other devices we have to allow somebody to read. I mean, reading is such an important such an important thing for us to do, and it provides so much satisfaction for people that I always send them to the low vision clinics and see if they can really enhance a person's ability to read. And they may be with mechanical devices, electronic devices, and people accept different devices. So you have to see what's best for that individual, for your mom. And I think at this time, then we have to wrap it up due to time constraints. But thank you, everybody, for your attention and for giving me this chance today. Thank you.